Okay, so let's say you are concerned that your child's having trouble breathing or noisy breathing, and you take them to the emergency department, which I'll abbreviate ER or ED during this discussion. Um, you probably already heard me talk about how I approach respiratory symptoms, breathing symptoms in the preschoolers. And the other reason I really like to get the right diagnosis early is if you show up in the emergency department for trouble breathing and the ER doc looks in the chart and it says asthma, more likely than not you're going to be discharged with a prescription for oral steroids. I've already talked about my concerns, particularly with repeated course of oral steroids. So that's another reason to, as much as possible and as often as possible, get the diagnosis right, ask for the referral early rather than later, because if you keep showing up in the ER and somebody wrote asthma in the chart, again, more often than not, you're going to be discharged from the ER with a prescription for oral corticosteroids, and this can happen repeatedly during a year and during the first few years of life. Not a good thing. Next, what would make an ER doc, decide on admitting a child versus discharging a child? There's no easy answer, but they often rely on oxygen saturation measurements, the pulse oximeter. This has been studied a little bit more, I would say, well, probably the same in asthma, but in the wheezy babies who are diagnosed with bronchiolitis. So what we know is the oximetry, the oxygen saturation measurements help in deciding who needs to be admitted, but they always delay the discharge date. Why is that? Because when you have a low oxygen level, and I'll talk about what I mean by low a little bit later, but if you have a low oxygen level, it's kind of a no-brainer. Even if the child seems to be getting better, they probably at least need to be observed for 1 or 2 nights, make sure their oxygen levels don't fall anymore. Conversely, as a child starts to improve during the course of their illness from bronchiolitis, their oxygen levels will come up slowly, and sometimes they may not achieve a normal, in fact they shouldn't. A child shouldn't remain in hospital until you have a normal oxygen saturation. That's why discharge gets delayed. People are focused on the normal range, and they don't want their child going home until it gets to the normal range. When the reality is that before we had oximeters, and I'm old enough to remember those days, point A. Point B is if the child is getting better, the parents feel the breathing is easier, they're eating, drinking normally, doesn't matter if their oxygen saturation is 90 or 92. The point is they're on an upward trajectory, meaning they're getting better. Let them go home. They'll heal better faster in their home, and probably less likely to pick up another virus, unless of course they have 2 or 3 older siblings who are going into school. So oxygen saturation helps with the decision to admit, delays the diagnosis, delays the time to discharge for the reasons I cited. Now, if I take that line of thinking to the decision on whether or not to admit the child from the emergency department, for me, I don't work in the ER, but as a pulmonologist, if the parents are familiar with, if we know A, what the child has, we got the right diagnosis, B, the parents are familiar in dealing with it, and C, the child is on the right medication, already has seen a specialist, it has the follow-up planned, even if the oxygen levels was 89, 90, parents felt comfortable, they've done this before, I would probably discharge a child, even at that oxygen saturation level. On the other hand, if this is the first time, parents are overwhelmed, child doesn't have a good working diagnosis of some previous diagnosis of respiratory or lung disease, then, even if the child was 91 or 92% in room air, if I had the feeling, or parents said, we had a terrible night last night, I'd probably admit the child for 1 or 2 nights just to make sure that you don't get 2 or 3 terrible nights in a row, and more importantly, that the child doesn't have an even worse night that the day they're in the emerge. So I can't, I really, and I shouldn't identify a single oxygen saturation level that means this child needs to be admitted versus this child can be discharged. Other than say, if they're in the low 80s in room air, they should be in hospital. I would occasionally discharge a child whose oxygen saturation was in the high 80s if all the other things were in place. So that's why I can't make a hard and fast cutoff rule there.